Hi, everyone. Thank you for those who are jumping on here. We're going to start about 12:03 just to give everyone a chance to hop on. For everyone who is just joining us, thank you so much. We will get started about 12:03, just making sure that everybody has a chance to log on. Okay, the clock just hit 12:03. So welcome everyone. My name is Debbie Elder. I am one of the community liaisons with Aurora Behavioral Hospitals. We have 2 hospitals here in Arizona, and we help adolescents and adults with mental health crisis, substance use issues. I'm always happy to share resources and information or to give you a tour. Just reach out to me. There are 4 of us on our business development team, Johnny, Val, Heather, and I, and then our illustrious leader, Angie. So any one of us would be happy to send you information or meet with you. We offer these CEU presentations once a month as a way to give back. We always appreciate all of our presenters. If you are a master's level clinician in Arizona and you have a topic that you are passionate about and would like to be a presenter, please feel free to reach out to me. A couple of housekeeping things, just so you know, everyone is muted and your videos are off. If you have any questions, you can put those in the Q&A. I will try to keep track of the Q&A and the chat, as will Madison. So if there are questions, just put them in there and we will get to them. Your CEU certificates will be sent out later today or tomorrow, as long as you checked that you need a CEU. And then, awesome. So we're going to get started here. I'll introduce Madison. Do you prefer Madison or Maddie? I've seen both.
I prefer Maddie. I feel like
okay, perfect. All right.
When my mom
is
mad at me.
Okay. So I like Maddie. All right. So Maddie is a clinical mental health counselor and the clinical outreach specialist supervisor at the OCD and Anxiety Treatment Center. She graduated from Westminster College in 2018 with a Master of Science in Mental Health Counseling, and she has 10 plus years experience in the mental health field within various levels of care, including short-term crisis services, outpatient, intensive outpatient, day treatment, inpatient, step-down facilities, and residential. In addition to her specialized training in exposure-based therapies, Madison has received training in eye movement desensitization and reprocessing and trust-based relational intervention. She also has a mental health officer certification as well as a state crisis worker certification. Maddie has been with the OCD and Anxiety Treatment Center since August of 2021 and has worked in both the clinical and marketing departments. In her free time, she can most likely be found playing with her dog, I love my dogs, and new kitten, watching Grey's Anatomy for the 100th time, or teaching indoor cycling classes at a boutique studio in Salt Lake City. She has been instructing indoor cycling for 2 years, and it is her favorite form of self-care. I love that. So, Maddie, I am going to stop screen sharing and turn it over to you.
Perfect. Thank you so much. Let me share my screen. All right. Well, thank you so much for having me here today to present on what is it really? Trauma, anxiety disorder, OCD. As she said, my name is Madison or Maddie, and I am a CMHC and outreach specialist supervisor with the OCD and Anxiety Treatment Center. We recently opened a new location in Mesa, so I'm very excited to be here today and hope to be able to connect with you all in the future. I am talking about these 3 classifications of disorders because those are kind of the 3 realms that we treat at the OCD and Anxiety Treatment Center. But also because there is a lot of overlap and high levels of misdiagnosis, especially between obsessive compulsive disorder and anxiety-related disorders. And so, during our time together for the next hour or so, this is what we're going to be going over, starting out talking about statistics that we're seeing as far as these disorders, the DSM-5 diagnostic criteria, the overlapping symptoms that we're seeing, the differentiating between the diagnoses, talking about misdiagnosis and the risk of inappropriate treatment, the most effective treatment modalities, outcome measures and assessments that we use at the OCD and Anxiety Treatment Center. Of course, there are a lot, but these are the ones that we use and find effective. And then I will end by giving you a little bit of information about the OCD and Anxiety Treatment Center. As she said, I will be looking at the chat during the presentation, and if something comes up that I will speak on later in the presentation or can answer at the end, I will, or if it's pertinent to the current slide, I'll stop and answer those. All right. So starting out, looking at statistics and diagnostic criteria. Kind of, why does this matter? Why are we educating ourselves on this? It's because it is so prevalent. With anxiety, which I don't believe a lot of people are going to be extremely surprised by, it's very prevalent. There are 40 million adults in the United States that currently have an anxiety disorder. And you'll notice throughout the presentation, something that we're really cognizant about at the OCD and Anxiety Treatment Center is that we refer to it as an anxiety disorder, because anxiety is a normal human emotion. Everyone experiences some form of anxious feelings. So we really try to call it an anxiety disorder. Currently, 31.9% of youth have an anxiety disorder. 31.1% of adults reported that they have had an anxiety disorder at some point in their life. And unfortunately, 36% of people experienced anxiety symptoms 10 or more years before they reached out for help or potentially got the correct diagnosis. With trauma, also, it may not come as a surprise that it is very prevalent. 12 million adults in the US have PTSD during a given year. And these are just people that meet the criteria for PTSD or acute stress disorder. This is just a small portion of people that have experienced an actual trauma. And about 6 out of every 100 people will have PTSD at some point in their lives. So yeah, Tim asked, is it fair to say that an anxiety disorder overlaps with trauma and isn't necessarily separate? Absolutely, there is some overlap. And there will be anxious feelings when it comes to trauma. And as I'll speak on later, looking at the differences of a diagnosable anxiety disorder versus a trauma disorder, but there's definitely, anxious feelings, anxious distress that comes up if you've experienced trauma. So the one that may surprise people is how prevalent OCD is. And frankly, I think all of these may not be completely accurate, because these are the people that have reached out for help, that are reporting that they're experiencing these symptoms. And as we know, with the stigma of mental health, there are a lot of people that aren't seeking out services. So with OCD, we're looking at it affecting about 4 to 9 million people in the United States. And 1 in every 200 children in the US has an OCD or related disorder. So that's looking at 500,000 kids and teens that have been diagnosed with an OCD or related disorder. That is about the same number of children that have diabetes in our country. And so that means that 4 to 5 kids at an average elementary school would be struggling with it. And at a medium-sized middle school or high school, 20 or more students. And unfortunately, the IOCDF Foundation, the International OCD Foundation, says that it takes on average about 14 to 17 years for people to get prior diagnosis and treatment. And really, it's because there is a huge misunderstanding about OCD. And I wouldn't be surprised if this 4 to 9 million is much higher, based on the fact that a lot of people aren't sure about the many different themes and domains that come in when it comes to obsessive compulsive disorder. As far as statistics on the time span of the pandemic, I don't have statistics for the United States nationally. These are the statistics currently that I just spoke on. However, as I can speak from personal experience, that we saw a huge uptick in people reaching out for help during the pandemic as well as after. So I'm sure as mental health clinicians, we've all seen that whether you had pre-existing symptoms, those are being exacerbated. And if you did not have, there were some anxiety feelings that were coming up or things like that. As far as if you're referring to obsessive compulsive disorder, a contamination type theme, and that fear of getting sick, I would say that there was definitely an uptick, at least that we noticed. So starting off first, looking at anxiety disorders. So anxiety disorders are characterized by persistent and chronic worry, fear, or nervousness. Symptoms that impair daily functioning, usually across numerous areas of life. But the big part of what differentiates between anxiety and an anxiety disorder is that the anxiety is out of proportion to the actual circumstance and what that situation calls for. And that's the difference between having anxiety, because there are definitely anxiety provoking situations we all go through, and actually worrying about it to the point that it becomes a clinical issue. So generalized anxiety disorder is a fear of or worried feelings about kind of everyday life topics, things that we all worry about, but out of proportion to what we should be feeling. So that could be school related issues, work, finances, getting sick, kind of just things that, our family getting hurt, things that we may worry about. It just takes up a lot more time, and people kind of get themselves stuck in that worry spiral that I like to call it. Social anxiety disorder is fearing social situations that you may embarrass yourself. And of course, social situations, especially being around new people, can be nerve-wracking. But again, out of proportion, you might see a lot of avoidance happening to not have to go into those social situations, or some isolation. Panic disorder is not just having panic attacks. Panic disorder is, there was panic attacks, but it is the fear of having future panic attacks. And that is kind of taking up a lot of your space of thought. Separation anxiety disorder is usually someone being anxious about having to leave an attachment figure, which for kids, that's pretty common, not wanting to have to leave their parents. But again, out of proportion to what we would see as normal anxiety. And then specific phobias. So maybe that's a spider or heights or needles, just those things that it's a one-off. These are the things that are making me feel anxious. Anxiety can present in so many different ways, and that is why it also can be difficult to diagnose, because the symptoms could be coming from a variety of things. A few examples: feeling nervous, restless, having a sense of impending doom, trembling, sweating, feeling weak or tired, breathing rapidly, trouble concentrating, potential physical symptoms such as GI issues or headaches or stomach aches. There's usually a lot of difficulty trying to control the worry. It takes up time and effort. It can make it hard to focus on other things. Sleep issues, having the urge to avoid things that trigger that anxiety, which hopefully you can start seeing when I mention some of these things. Your brain is kind of turning of, but people may feel that way with OCD, or they may feel that way with a trauma disorder. And that's why just looking at kind of those symptoms isn't the only place we should be going when we are making assessments, because a lot of them look similar as far as symptoms go. So I'm going to spend a little bit more time on obsessive compulsive disorder, just because I spoke about that there is such a misunderstanding about this disorder. So OCD is characterized by the presence of obsessions and compulsions that have a significant negative impact on numerous areas of functioning. So with the obsessions, those are intrusive, unwanted thoughts, images, urges that occur repeatedly, and they usually feel outside of the person's control. These are really unpleasant, typically cause significant worry, anxiety, and distress. So there's the obsession side, and then we have the compulsions, which can also be referred to as rituals. And these are behaviors that people feel like they must perform with the intention of getting rid of those upsetting feelings caused by the obsessions. There's also some forms of OCD where people feel like if they don't do this, something bad's going to happen. And for compulsions at our center, we refer to those a lot as neutralizing behaviors, because the function behind those is they are trying to neutralize the perceived threat that is coming up with those obsessions or intrusive unwanted thoughts and images and urges. So behind every OCD obsession that people are having, they're all fear-based. And so it's something that we are fearing could happen. So ones that people are really familiar with and people get stuck on, the only forms of OCD are people that are worried about germs and they have to wash their hands a lot, or they spend a lot of time cleaning, or people that really need things organized, which, yes, these are domains of OCD, where there are people that have that fear that they're going to get sick or die, or they're going to contract some sort of disease. And so the compulsion there to neutralize that perceived threat is excessive washing, cleaning. And then with something as far as a just right type theme OCD of people that need things to be organized, and not just people that are saying, that's another stigma, people saying, I'm so OCD because I like to have my clothes color coordinated. And the difference is that it's not just a preference. It's something that people have to do, or they're going to be feeling an extreme state of discomfort. So other things that people may not know about domains, the two biggest domains that we see are scrupulosity as well as perfectionism. So scrupulosity is, there's a religious and moral, where the fear is either that you're a bad person or that you're going against the values of a church or a scripture. And it is, some of the compulsions that might come from that are overreading scriptures or having to confess more often. Big ones for a lot of OCD themes are reassurance and validation, and having to get reassured that you're not a bad person. Maybe you have to reread scriptures 5 times until you feel like you've actually taken it in and have gotten the message. Perfectionism, where people feel like they just have to do something perfectly, where this is kind of, I think a lot of people that are teens and kids are getting lost and not diagnosed correctly, is they can look like really good students because they have that perfectionism obsession, where the compulsions are they have to reread or rewrite, or they have to review their homework 10 times before they submit it. And even after they submit it, they are looking at it. Or people that are in social situations, and keep in mind, this is different than social anxiety, but feeling like you have to do things well enough. So it's not necessarily a fear of embarrassment, but it's a fear that you're kind of engaging in that social situation well enough. And so a compulsion could be having someone read over your text messages before you send them, or after a social situation, asking somebody, was that weird? Did I do okay? And so those are two of our biggest themes, but some other themes that may come up are sexual or pedophilia OCD, where there's disturbing and unwanted thoughts of a sexual nature. And pedophilia OCD would be someone that is terrified, fearful that they are going to or have sexually violated a child. And the thing is that these things haven't happened. Just for whatever reason, their brain is kind of convincing them of this fear and these thoughts. And so a compulsion we might see with that are people that will drive an extra 20 minutes to avoid going by a school. Or again, a lot of validation and asking somebody like, was that weird? Could I have grazed up against that person and not known it? And again, I think that especially with OCD and some of these themes, there is a huge stigma and a lot of shame surrounding it, because people, if they're having these thoughts, what does that mean about them is what we hear a lot is, are they a bad person? Something's wrong with them, but really it's just they don't have control of these thoughts. Another one that has some shame behind it and can be really misdiagnosed is the harm theme OCD, where people are afraid that they are going to harm themselves or that they're going to harm someone else. And when we as clinicians hear, I think about killing someone or I think about harming myself, our red lights going off of duty to report. and, we'll send them to an ER or to get a crisis worker. But if you dig a little bit deeper, you'll notice that the intent's not there, that they're just having these thoughts of what if I did this? And they don't want to do it. That's the thing, is with these thoughts, people know for the most part that they are illogical, that it's not something that they want to do. It feels inconsistent with the person that they are. And so a compulsion for a harm type OCD might be to have someone remove all of the knives from your house, or making sure that you avoid certain aisles in the Home Depot that has rope, or something like that. We had someone that they were convinced that they had hit someone with their car, and so they would circle back around to make sure that there was not a body or something in the road. So I think that's the biggest thing, that if you get anything out of this presentation, is to know that OCD is so much bigger and, broader than what people are aware of. And that's why I mentioned the 4 to 9 million people, is that how many of those people have been diagnosed because they have contamination type fears? How many people, that have harm type fears or scrupulosity are not getting diagnosed, because a lot of clinicians don't know that these are a part of OCD. And, I'll be honest, going through grad school, I didn't learn about, these types of things. It's just kind of the broad, what the DSM says. And so being able to get this specialized type training, it's really opened my eyes to even my own clients that I have, missed in the past. All right, going on to trauma. So, two main diagnoses here: post-traumatic stress disorder and acute stress disorder. So with either of these disorders, there needs to be an exposure to a traumatic event. And as we know, trauma can look different to everyone. Someone could be traumatized by something that I wouldn't even bat an eye at, or vice versa. And so really talking with the client, being able to gauge that there was an event that brought on some new symptoms. In the next slide, I'll show you some of the symptoms, 9+ symptoms of PTSD that we'll be looking for. The difference between these two is mainly the duration. So acute stress disorder would be 3 days to a month after the trauma occurred. And once it passes that month, then we're looking at post-traumatic stress disorder. But usually we're seeing intrusive thoughts, we're seeing anxious feelings, we're seeing distress, we're seeing avoidance, we're seeing potentially mood alterations, reactivity, sleep disturbances, significant distress, impairment in functioning. And again, as I'm talking about this, I've said this with the other two disorders, there's just a lot of overlapping symptoms that are coming up. So it's really important that we're digging a little bit deeper and kind of chasing that why of as what is actually going on. Could trauma in a pre-verbal infant's life show up in a child's life as OCD? Absolutely. So when I do a differential diagnoses slide about PTSD and OCD, it's actually fairly common to be co-occurring. And OCD, there's not a complete, this is where it comes from. But it can be genetic, it can be trauma is kind of bringing up some things of OCD. So definitely those two are correlated. So looking at some of the criteria with kind of the 9+ parts of the DSM, reliving or re-experiencing the event. So that's kind of the well-known flashbacks or nightmares or triggers. Hyperarousal, so having difficulty sleeping, feeling angry, being jittery, negative feelings or beliefs, either about yourself, unable to trust other people, feeling guilty or ashamed, losing interest in things you used to enjoy, and then a lot of avoidance. So avoiding crowds, avoiding certain smells, sights, avoiding talking or thinking about the event, which, as I was talking about earlier, avoidance is a big compulsion for OCD. And also can be a reaction to an anxiety disorder. So again, we've got a lot of overlapping symptoms coming up here. So now looking at those overlapping symptoms. So all of these we've kind of mentioned that we're seeing an impact on functioning. We are seeing whether that's work, whether that's school, whether it's relationships, and irritability. We are seeing anxiety-related symptoms through all three of these realms of diagnoses. There is the lack of interest in activities. You may experience disturbing or unwanted images, have trouble concentrating, have difficulty sleeping, avoidance, feelings of guilt and shame, repetitive thoughts and behaviors. And I know when I read some of these, there's even other diagnoses outside this that come up, thinking of something like ADHD. Is it a attention type disorder, or can they not sit still and pay attention because they are having unwanted or disturbing images, or they are having such, anxiety that they can't focus? And so I think that it's just really important as medical professionals to take a step back and, kind of consider everything that it could be and rule out based on the, information that we're getting from our clients. So the reason that the OCD and Anxiety Treatment Center works within these realms, specializes in OCD, anxiety disorders, and trauma-related disorders, is because they all fall under what we call the false alarm system. So as I've said earlier, we've got neutralizing behaviors, which any behavior that tries to neutralize a perceived threat. Those can also be compulsions, but it can also be things that we're doing with in response to anxiety disorders or trauma. So thinking about the brain alarm system, every single person has an alarm system in their brain that is meant to warn them when there's danger or a threat. So there's a trigger of some sort. There is a perceived threat. So let's say a bear walks into your room. Your brain is going to say, oh, wow, that's a threat. We need to do something about it. So you get that kind of distressed feeling and you have the urge to do something about it, as we should. And then we engage in whatever that behavior is to try to neutralize the perceived threat. Maybe that's a fight, flight, or freeze type situation where we are running from the bear, we're fighting the bear, we're hiding, you're just freezing and doing nothing. So you can kind of cognitively get away from that situation. And then, once, let's say, we perform this and we get away from the bear, your brain is like, all right, we're good. And that alarm system went off correctly because it warned us of something, we did something about it, and the distress was gone. So the people that are experiencing things like OCD, anxiety disorders, or trauma-based disorders, is that their alarm system is going off falsely. It is going off, telling people that there's a threat when it's not there, or it's out of proportion to the situation. And it feels just as real as if there is an actual threat, a bear walks in. And that's why when people say, well, just don't wash your hands that often, or, just don't confess that much, or don't reread that how many times. They can't, because their brain is telling them it's as real as a threat, as if there actually was a threat that all of us would need to take action from. And the issue is that with, let's say, OCD, we kind of call it this cycle where they have that fear, they have that threat come in, and then the compulsion, they do something about it. And whether that's washing hands, whether it's reading scriptures, whether it's avoidance or asking for validation, it completes the cycle and it confirms to the brain that there was a threat. And so that your brain thinks it did a great job and it's going to keep alerting in situations similar. So that's why you hear a lot of the time where, okay, this makes me feel better temporarily, but then it just comes right back. And it's because your brain thinks it's doing its job, it's doing what it's supposed to do. And so with the type of therapy, all types of therapy, we're working to kind of rewire someone's brain. And with our treatment, we're trying to rewire so that alarm system is going off what it's supposed to. So less frequently and less severely, and also teaching clients how to recognize when this false alarm system is going off, because it is common for people to have, potentially co-occurring diagnoses of social anxiety disorder and then a theme of OCD. And so if they can recognize that this false alarm system is happening, then they can take the steps they need and use those skills to be able to be more in control. So looking at differentiating between these diagnoses. So the biggest one, again, if you get anything out of this presentation, really just looking at how to weed out, is it an anxiety disorder? Is it OCD? So while it's most people with generalized anxiety disorder do not have OCD, it is very common for people with OCD to also have GAD. And it really is, GAD is occasionally misdiagnosed as OCD, but OCD is frequently misdiagnosed as GAD. I can't tell you how many intakes I did that they're like, I'm wasting your time. I've been diagnosed with an anxiety disorder since I was 10. And then they would start talking for 10 minutes. And I was like, that is OCD. And so it really is alarming how many people, do struggle with these things, and they just haven't found someone that knows enough about this specialty that they aren't able to, get the correct treatment. So looking at the chart over on the right, as far as the kind of content of the worry. So with GAD, the content of the worry is the same as what the average person worries about, but the frequency and intensity is higher. So there is the threat of school concerns or money concerns or relationship concerns, but the frequency is higher. With OCD, there is a misperception of the threat. So as I was talking about, the alarm system's falsely triggered, and it's something that logically they know they shouldn't have to worry about, but that doesn't matter because their brain tells them they have to do it anyways. Neutralizing behaviors are present with OCD. There's always compulsions. With GAD, there can be some neutralizing behaviors, but not always. For both, it's really difficult to tolerate uncertainty. Challenging thinking areas can be effective with the generalized anxiety disorder, but with OCD, challenging thinking errors can function as reassurance. And that's why some people that have been in talk therapy for 10 years that are not getting any better is because kind of in that 50-minute session, they're getting a lot of validation, a lot of reassurance. And so really it's just we're feeding into this cycle of OCD. With GAD, you're usually looking at worry with a variety of topics at different domains. And with OCD, there's usually a single topic. You can really find one thing that you can look at the why of, like, what is the fear here? What is the threat of this thing that you are obsessing about? So the two big essential differences to look out for with these two diagnoses would be, one, the nature of the thoughts involved. So GAD, it's usually more realistic, more common, real life concerns on a variety of topics. With OCD, it's more atypical, worry may be improbable, and it's more so on that single topic or fear. For as far as the behavioral response, GAD, the primary behavioral response is worry. You just get stuck in that worry, and it's often like worry is the obsession itself and the compulsion. And then with OCD, you're going to see numerous behavioral responses where we're seeing those compulsive type behaviors. And I will touch on in a little bit what we use as far as treatment options for OCD. We are exposure-based, which is the gold standard for treating OCD and anxiety-related disorders. So I will get to that a little bit later. So next, looking at GAD versus trauma. So individuals with generalized anxiety disorder usually have a long and consistent history of worry about a variety of situations, but there isn't something that you can stem back to that there was one certain instance that brought about these anxiety-related symptoms. But individuals with trauma often experience these intense anxiety symptoms, the flashbacks and everything we talked about earlier, in response to a major life event that is traumatic to them. There can be some generalizing across situations, but the experience is often limited or linked to this major life event. Something that was really helpful for me is thinking about where the distress is focused. So distress coming from the past would be trauma. Of course, there is some future outlook. What if it happened again? But a lot of the thought process is involved around the thing that happened in the past. Or is it an anxiety related disorder where it's more of that worry about the future of, this relationship or financial concerns, or am I going to do well in school? And keeping in mind that these diagnoses can coexist. A traumatic event can make the anxiety associated with GAD more severe. It's kind of just looking at the time frame. Was there these types of worries prior to the traumatic experience? If so, then maybe GAD was there, and then when the trauma occurred, it's got that diagnosis. But the generalized anxiety disorder was amplified because there may have been some confirmation of some of those worries with the trauma. So OCD and trauma, which I find extremely interesting, is that the co-occurrence of these disorders is 1 in 4 individuals with PTSD is also experiencing OCD. In OCD patients with a diagnosis of PTSD, 10.6% had the OCD diagnosis emerge either co-occurring or after PTSD. There is also a post-traumatic OCD type theme. And then 4.1% had an OCD diagnosis that occurred before PTSD. So again, it's just always so important to be able to look at the timeline of when these symptoms started coming up for people. So some things to consider: what is the function of the behavior? What triggers the behavior? Is the behavior logically connected to the feared harm and done in reasonable frequency to protect oneself? So is someone responding this way because they did have a trauma that confirmed some of these feelings? Or does the client have a sense that the behavior is illogical with something like OCD, or that the individual is unable to be finished with the behavior when he or she would like to? And that's where a lot of the compulsions come in, of it's things that they wish that they didn't have to be doing, but their brain is telling them that they absolutely have to because of that alarm system. Again, looking at the timeline of where are the thoughts focused. PTSD is looking at the past. OCD is usually that, what if this happens? What if I do this? So looking at the future. A lot of the behaviors, which we can see repetitive behaviors in both PTSD and OCD, is, again, what's the function? Are they doing it to prevent trauma from reoccurring, or is it done to prevent imagined threat from coming? And usually with PTSD, they can engage in that behavior and, they're able to move on. But with OCD, it usually is coming back pretty soon, and they have to keep doing it over and over. OCD usually has a more rigid set of rules where people kind of are very intelligent as far as for whatever reason, if I do this thing 4 times, I feel better. Or if this number is even, or if I reread something this many times, then I'm going to feel like the threat is diminished. Looking at avoidance, which can be both of these avoiding scenarios, can be a compulsion. And also, avoidance where you may be triggered from trauma memories would be PTSD. So also looking at the underlying function. Are we avoiding painful memories and worrying about being re-traumatized, or being kind of triggered by the trauma that had occurred? Or are we, with OCD, trying to prevent feared consequences from happening? So outside of just generalized anxiety disorder, OCD, and trauma disorder, there's also a lot of other ones that could overlap. So with social anxiety disorder, is the person worried about humiliating themselves in front of others? So that would be social anxiety. Is it a trauma response that they are, avoiding this situation? Or could it be an OCD fear of contamination or perfectionism or harm that's making them avoid and appear anxious in these social situations? Separation anxiety disorder, is it anxiety coming from separating from an attachment figure? Or is it a trauma response because something had happened, with someone that they had a connection to? Or could it be an OCD fear of danger or harm, that if they are away from an attachment figure, something bad may happen to them? Panic disorder, is it someone that's afraid of having panic attacks, or are they having panic attacks because of the symptoms they're experiencing from some of these other disorders? And then specific phobias, are they panicked about a specific object or situation, or is it more broadly based that could indicate something like generalized anxiety disorder? Is it really just this one thing they're worried about and perseverating on, or can we broaden it and see a few more areas of worry that they're having? Could it be a trauma response, or could it be an OCD fear of contamination or perfectionism, just right, health, etc.? So really the, really big thing is to always look at where that anxiety is stemming from, and just being aware and asking kind of the questions to feel like you are feeling confident about where exactly those anxiety feelings are stemming from. And of course, always referring to the DSM-5 to make sure I'm meeting criteria. But with OCD, there's, it's obsessions, compulsions. And so it's really can be difficult to know if it's OCD or not. And the IOCDF website is really great. They talk about a lot of the domains of OCD. Postpartum OCD is one that we see. And so there really is just so many. OCD can latch on to literally anything. So this is kind of, you could have this in front of you, but it's something that I just always have in my mind when I'm doing assessments or focusing on, trying to find the why of the behavior. Is it fear-based? What's going on? Is to kind of use a chart like this of where's the symptom focus, and also, of course, always looking for suicidality, self-harm. And if there's high acuity there, we're always going to look at that first. But just really staying curious and being able to kind of have something like this in your head to rule out or to potentially dig a little bit deeper. So talking about the risks of misdiagnosis and inappropriate treatment. So this study makes me sad, but it also really shows how, really skilled clinicians aren't even aware of, how prevalent OCD could be, because people aren't aware of the themes and domains that are out there. So I believe this study was in New York. They asked 208 primary care physicians to complete randomized vignettes, and each vignette focused on one of the common manifestations of OCD. So it would say, this person is struggling with, feeling like they are a bad person, or this person often thinks about harming other people. And they asked them to put, if the diagnosis and the treatment plan, and the overall misidentification rate was 50.5% of people that said that it was more of a generalized anxiety disorder rather than OCD. Why? Why are we misdiagnosing? Because one, OCD was listed under anxiety disorders in previous editions of the DSM. And now it's listed as its own classification. But as I said, personally, when I look in the DSM at OCD, it's really not extremely helpful. And that also many clinicians are just not aware and do not understand the various ways that OCD can be expressed. If OCD, I've kind of touched on this before, but if OCD is misdiagnosed as GAD, a general kind of talk therapy, cognitive behavioral approach that doesn't include any exposure may do them more harm than good, because we may be feeding into their compulsions and their neutralizing behaviors without knowing it. And also, if OCD is misdiagnosed or mistreated, it really can extend and intensify a client's suffering tremendously. Looking at one confusion is that people, may get to the point where they don't understand why treatment's not working, that maybe there's something wrong with them. Maybe therapy just doesn't work for them. Maybe they'll feel like they're a personal failure and have feelings of guilt or shame or hopelessness, and also can cause a big breakdown in communication. If you've been seeing a therapist for however long and you don't feel like you're getting better, that can really cause a breakdown in communication. It also can bring about incorrect medication, and a client could be put on medication for an anxiety-related disorder, and really it's not going to be doing anything to help, depending on the diagnoses they have, and they could experience side effects. They actually may have worsening symptoms rather than getting better. And especially as I touched on earlier with ADHD, if someone is feeling really hyperactive or they can't focus, and it's not because it's ADHD and that attention, and it's actually because people are not able to focus or sit still because of trauma triggers or anxiety related feelings or OCD intrusive thoughts. If they're put on a stimulant medication, this can cause impairments in working memory and other areas of cognition. And overall, just a worsening condition. Symptoms will likely worsen. More severe impact on functioning can develop. Really, they may discontinue treatment thinking that it doesn't work, and they may have a negative stigma towards therapy after that and not be willing to try maybe another form of therapy or therapy at all in general. And also a huge one is suicidal ideation, especially for OCD sufferers. It was found that 10% of those with OCD have attempted suicide, while 1/3 of them have current suicidal ideation. And 1/2 of that group may not have current, but they have had suicidal ideation at some point, kind of in their life due to these symptoms. So really just, that's why we got into this field, is we want to help, we want to help people get their lives back and feel better. And a huge part of that is for us as clinicians to really do our due diligence to make sure that we are properly diagnosing and getting people to the treatment that's going to help them best. So looking at the most effective treatment modalities, we have for OCD and anxiety-related disorders, they are best treated with cognitive behavioral therapy. However, cognitive or CBT is a broad umbrella term that encompasses a wide variety of interventions, which not all of those are appropriate in the treatment of OCD. So what we utilize at our center is exposure response prevention and dialectical behavioral therapy. And as I said, exposure and response prevention really is the gold standard for treating OCD and anxiety disorders. So there's the exposure piece where you're facing your fears by intentionally placing yourself in situations where you are vulnerable to your perceived threats. So you're facing your fears on purpose. And this can be a very scary form of therapy, because even just thinking about it, that false alarm system is going off of kind of the brain is like, I have been warning you against this. Something bad's going to happen. Why would you voluntarily face these fears on purpose? And then there's the response prevention piece, where we're remaining vulnerable to those perceived threats by resisting, preventing, or blocking those neutralizing behaviors or compulsions. And so with thinking about a exposure example for contamination might be, you have that threat go off that you're going to get germs because you're holding your hand on a doorknob. And then instead of immediately going and washing your hands, you're sitting in that discomfort and, getting kind of not letting that cycle complete. And so when you do that over and over, your brain's going to see, oh, I may not be going off correctly with that false alarm system. And something like potentially scrupulosity. We have had people that aren't able to, read their scriptures as many times as they want. I actually sat in on some exposures earlier, and there was someone that felt like if he didn't get, it was a perfectionism, if he didn't get every detail of a story, that something bad was going to happen. And so he had me kind of tell a medical related story, and that had a lot of detail, and he was typing as I spoke. And he just kind of got what he got. And so he's feeling really distressed that he had missed some aspects of it. But he had to sit through that. He said, usually his urge would be to ask me for more details, ask me to stop, ask me to slow down. But it's kind of just sitting in it, doing it quick and dirty, and going through that. So we do get really creative with exposures. But something that's really important to us is remaining values consistent, especially with something like scrupulosity. Some people think, oh, you're trying to pull them away from their religion. And no, really what we're trying to do is getting them back to a place where they have a healthy relationship with it. And we're never going to make anyone do any exposure that they are not comfortable with. All exposures are made collaboratively with their therapist. And it's kind of fun to see the creativity that can come from some exposures. With social anxiety today, another person had to bring up a controversial topic that him and I would have different opinions on. And he had to disagree with me and, kind of sit with that. And something that he knows is his neutralizing behavior within his social anxiety is the need to over-explain or to backtrack. And so it was kind of just, here's my opinion, and that's that. So we get really creative with those exposures, but really we're just trying to hit that threat, make it so they are sitting in that discomfort and not neutralizing. And that's how we rewire the brain to get it so that false alarm system starts working more accurately. So with trauma, we know there's a lot of different evidence-based interventions, EMDR being one of them is a really popular one. Here at our center, we utilize a dialectical behavioral therapy prolonged exposure. So what that does, it aims to help clients stop avoidance and instead confront trauma-related thoughts and situations so that trauma can be effectively processed. For this, we have two different types of exposures while leaning on a foundation of DBT skills. So we have kind of imagined exposures and processing where they may revisit the traumatic experience in their imagination, write it down, describe it out loud, followed by that processing and talking about emotions and thoughts that were coming up. And then there's more of a kind of in real life exposure. So potentially confronting situations, gradually starting to approach situations they've avoided because it reminds them of the trauma or therefore perceived as dangerous. So an example of an exposure I sat in on recently, which the timing worked out well. There was someone that it was their first exposure, and we're not day one throwing people into exposures. It really is, we're building them up, allowing them to get to a point where they have the skills based so that they can handle those distressing feelings that can come up during exposures. But there was one person that had written, it was her first exposure, and she had written just words on flashcards that were related to her trauma, but nobody else would know that. Like there was one that was cat, there's one that was like Coca-Cola, and all she had to do, which not all, because it was very distressing for her, but she would read the card out loud to a group of people, and she would just have to sit there and tolerate it. Nobody said anything, no one asked any questions, and then she would move on to the next. And then there was someone that was graduating, and she had been there obviously for a long time, and she would read out the word, she would explain the story and how it connected, and then she would let people ask questions. So that just kind of shows a difference, an example of layering of exposures of, we're starting out here and then we're building up to here, where we're adding in a lot of different situations because that's what life's like. It's uncertain, things can happen, and kind of being able to, get yourself in a point where you are facing those fears and kind of learning that it's okay. So we only use exposure-based interventions here. So we don't use EMDR. So we're just using the DBT PE model. Looking at the outcome measures and assessments that we use. For OCD, we're using the obsessive compulsive inventory. We used to use the Y-box. Both we like. GAD, we're looking at the GAD-7 as the outcome measure and the Penn State Worry Questionnaire as a screening measure that can provide specific clinical information. For PTSD, it's the post-traumatic stress disorder checklist as the outcome and difficulties in emotional regulation to assess readiness for exposure work. Panic disorder, the panic disorder severity scale, social phobia inventory for SAD, and then body dysmorphic disorder for symptom scale for body dysmorphic disorder. And we are always using the Columbia Suicide Severity Scale and the CAMS suicide status forms to assess for suicidal risk for our clients. So here are some references. And now just taking a little bit of time to talk about the work that we do at the OCD and Anxiety Treatment Center, and then I'll open it up to questions. So we are we started out in Utah. So we have one in Bountiful, Utah, and we have South Jordan, Utah. And then we just recently opened in Mesa, Arizona. We can do telehealth for adults. We have made some exceptions for kiddos or teenagers. But we found it's a better experience for the kids being able to be in a group and be surrounded by their peers. So telehealth we can do for 18 and up, but we can take as young as 5 for our kid and adolescent program. So we've gone over a lot of the diagnoses that we treat. So obsessive compulsive spectrum disorders, so OCD, as well as body dysmorphic disorder, with anxiety related disorders, generalized anxiety, social anxiety, panic disorder, specific phobias, and then our trauma, PTSD, and acute stress disorder diagnoses. And lastly, we look at body focused repetitive behaviors. So things like trichotillomania, hair pulling or excoriation disorder, skin picking, chronic nail biting. And that's something that I really like because I do not know many people that treat that. So yeah, these are kind of the things we focus on. And one of these diagnoses needs to be primary. If there's a mood type disorder there, that's fine. It just can't be primary. So if someone's coming in with something like ADHD or major depressive disorder as primary, we're going to refer them out just because, we specialize, we know what we do, we know the client it works for. So we have an outpatient program, which has immediate openings in Arizona. And then our real bread and butter is our intensive outpatient program. So that is 5 days a week and it's 3 hours a day. And it is average length is about 9 weeks. And after 9 weeks, we're seeing a 50 to 70% reduction in symptoms, which is really exciting. And after that, we're dropping down into a aftercare, more outpatient type level until there's further symptom reduction. In our IOP, we're doing those assessment measures every Friday. So we're really keeping track of where they're at. And outpatient, we're doing those every time. With our little outpatient program, that would be our 5 to 7-year-olds, and that incorporates play therapy with some exposure-based models. And then, as I talked about, the body-focused repetitive behaviors treatment. And we have free alumni and educational groups. We have the alumni for youth and adults. It's free once you finish the program. And then we have an educational course called Live Uncertain Academy that we have twice a month, that it's really just kind of general education for people curious about the diagnoses we treat, or I presented on one this week about the difference between outpatient and IOP and other higher levels of care. So that's something that I can, send to Debbie, that we have twice a month, and it's free to whoever wants to join. So kind of why us, we've got that exposure-based treatment. We are highly specialized. None of our clinicians or our clinical assistants who are bachelor's level, highly trained individuals are able to, who may be, sorry, I was just reading a question. That's a great question. But before they're sitting in with any clients, personally, they are doing a lot of observations. They are doing just a lot of self-directed trainings as well as live trainings. As I said, values consistent is so important to us. We are never forcing anyone to do anything that they don't want to do. They can always stop an exposure. Of course, we're going to encourage people to get out of their comfort zone because, the bigger the threat that they can deal with, the more effective an exposure is going to be. Something that I really love about our program is that sense of community. My younger sister went to our program, our IOP, about a year before I worked here. And that was one of the biggest things she got out of it, is she had some of those not as well-known themes of OCD. And she just said, when I went there, I felt like I was dumb, that nobody would understand, that something was wrong with me. And then when she got there and was able to engage in some of those group exposure sessions and things like that, she really just felt that sense of community, which, you can only get kind of in that IOP setting. In our youth program, we do require family involvement. So whether that's with their individual therapist or, within our IOP, we have DBT skills group and specialty skills groups. So that's something that family will join in on. And, we really just want to be able to help people kind of have the symptom reduction and have help inside of our clinic as well as outside. So sometimes we've worked with teachers, friends to be able to help them, especially those that are really validation seeking and people don't know how to respond to that. And they want to be helpful, but they kind of just get stuck there. We also highly encourage any kind of attachment figure involvement in our adult programs as well. We coordinate really closely with schools and also jobs to help people get in. So working with FMLA as well as school accommodations, because with our IOP for our youth and adolescents, it's from 2 to 5 in the afternoon. So they do usually miss an hour of school, which frankly, they're usually not functioning in school anyways. So the school is usually very happy to work for us or work with us. And for in Utah, we have a program that we're working with one of the school districts really closely, where they provide funding for some of their students to get treatment if needed. Also, as I said, telehealth is available for adults. And, if there are some kiddos that they are not able to leave their home, we can look at a option where, they could start at home and then transition to our program. And as I said, 50 to 70% reduction in symptoms. We know our program works and we have the data to back it. So yeah, that's kind of my presentation. But yeah, I am happy to answer any questions. As far as insurances, right now we're paneled with pretty much everyone: Aetna, Cigna, Optum, TRICARE, U of U for Arizona. We also are paneled with some access programs, so Medicaid, some tribal programs within that. And we can take on an outpatient basis right now, Blue Cross Blue Shield, and hopefully we will be paneled with them for our IOP program soon. And then in our Utah facility, we take pretty much all major insurances, with the exception of currently we don't take Medicaid or Medicare. But we do also work really closely with the clients to be able to potentially get a low interest credit card. We work with banks or a loan, or work with payment plans. So we know our treatment works. Our IOP is really client-centered, client-driven. So if someone doesn't need DBT skills, they've already kind of done that in previous weeks, then maybe they'll do group exposures instead of doing that DBT. And kind of looking at what it typically looks like is once a week with their therapist, but if that needs to be more, we can adjust. Process groups, group exposure, DBT skills groups. So it's really flexible. And so that's something that's really exciting about what we offer. What options for therapy do you recommend for those that are waitlisted for the program? So in Utah, we do have a wait list for our outpatient program, but we do have immediate openings for our IOP. And in Arizona, we have immediate openings for both our outpatient and our IOP programs. And as far as people that are waitlisted, we really, for our Live Uncertain Academy, that was a big audience that we're catering to, is having them kind of just feel like they're having access to services and on an educational type level, learning a little bit more, knowing what they're being prepared for. And also we are emailing them kind of throughout their time on the wait list periodically of, things that we can do, worksheets and things like that. But I really recommend, especially for OCD and anxiety related disorders, trying to find that exposure-based type treatment. Someone had asked, what is an example of a exposure for someone that has an OCD related fear of their child dying? So something that I've seen people do of like that sort of a thing, there's kind of in a similar realm, people will have a fear that someone's going to break into their house or something bad's going to happen. And so they have to check the locks a certain number of times, check the stove to make sure it's off. And so I think that the biggest thing that, our slogan is live uncertain. And because things happen. Like, yes, you could get sick. Yes, someone could break into your house. Yes, awful, but your child could die. And so something that we have an exposure I can think of off the top of my head is someone read a news article or watched an interview with a parent that their child had died. And it's really just sitting in that discomfort. Or even having to write out a fake story of that actually happening. And of course, we don't want that to happen, but and it is an awful feeling, but it is sitting in that discomfort because there is uncertainty and things can happen, and not feeling as distressed by the idea of something like that happening by exposing yourself in that way. Do you treat post-acute withdrawal due to trauma-related circumstances while using substance problematically? So some of our exclusionary criteria is active eating disorders, substance abuse, and psychosis, and suicidality. And we don't have a nutritionist on staff. We don't have medication management, so we'll refer out for those things. And so to engage, especially with the nature of exposure-based therapy, it is a tough type of therapy. And so we really, substances can be such a coping skill that we really would refer out to be able to get people to handle those symptoms in a separate situation before coming back to us. And we have some really great information on our website. We're working on, it's almost done being redesigned, but there's some great book recommendations and blogs on there, a lot of information about what we do, some videos that we've made. So that's always a good resource. I've listed on here our office number, our fax number, as well as my email. So feel free to reach out to me if you have any questions or any, client related consultations that I might be able to help with. And if, you did have a referral, you could either give the client that office number and they could call in to schedule an intake, or you could fax over some clinical information or email me, and I can help get that process started. So our admissions team could reach out to a potential client to get them scheduled. And even if, you're not sure what's going on, we're happy to do an assessment to be able to just kind of give them an idea of what they may be struggling with. We'd give them a treatment recommendation. So even if some clients are really wary about maybe exposure-based therapy or just getting therapy in general, we are happy to, at least do that assessment.
Awesome. Well, thank you so much, Maddie. This was just fascinating. I know we kind of talked about my daughter when we were, when you were showing me around. I encourage anybody, set up a time to go tour. It is beautiful. I was just super impressed with it. And, if you're here locally in Arizona and you're looking for options, I would highly recommend referring. They do great work, and it was really cool. We actually met a young man who I think probably was working on some of his exposure therapy that came up and introduced himself, and it was just super cool. So thank you. I took tons of screenshots. I am going to do that really quick. This is just a QR code. If anybody wants to leave us a review, we always love having reviews. No pressure to leave a review if you don't want to. And our next webinar will be April 28th, and the title is going to be Incorporating Mindfulness into Clinical Practice. So if you're not on our list for getting notice of these, send an email. Happy to add you to our contact list. We stopped doing the Eventbrite just because it was complicated to have to do 2 separate registrations. And so if you're having trouble finding us, shoot an email over and we will get you on our list. Trying to think that the CEUs, again, will go out tonight or tomorrow. I will send a copy of the PDF from Madison's presentation with that. And then the recording should be up in about 10 days. I will email everyone who registered the recording link as soon as we have that up and running. We don't post that ourselves on our website. That's done by our someone outside of our company, so it takes a little bit longer. If you have any questions, if you're in need of any mental health resources, any services, Always, please feel free to reach out. Again, thank you so much, Maddie, for presenting today. If there's anybody out there who would like to be a presenter, please send me an email, because this is great information, not just for clinicians, but for people like me that is not a clinician, but has a daughter who really struggles with this. So absolutely loved it. I hope all of you have an amazing rest of your week and a great weekend. And we are done. So thank you. Have a wonderful day.
Thank you for having me.